Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel, and today we're going to be talking about perimenopause with someone very special, an old friend of mine. Her name is Dr. Jila Senemar. Dr. Jila, as she's known, is a board-certified OBGYN with over 20 years of clinical experience based in Miami, has served in academic roles, including assistant professor at the University of Miami, is the founder of Jila MD, a concierge practice focusing on perimenopause, menopause, hormone therapy, and longevity medicine, and is also the founder of the Miami Menopause Collective and Empower Her Miami. She has contributed to medical textbook chapters in gynecologic surgery and adolescent medicine, and is a frequent public speaker on women's health topics. She has also just launched a new podcast called Her Time, Her Health, focused on health and wellness in perimenopause and menopause. So welcome, Jila. How are you?
I'm wonderful. Thank you for having me, Kirti.
It's so great to have you. So, okay, I'm going to give people a little background.
Yes, of course.
Jila and I have known each other, I think it's like 28 years, almost 30 years.
Yes.
If my dates are correct. Mm-hmm. And we did residency together at Long Island Jewish Medical Center. Uh-huh. I was a year ahead of her. Right. And we frequently did call together. We spent so much time together. And honestly, you have so much dirt on me. Like, honestly, like if anybody,
I think we have dirt on each other. I think it could go both ways, Kirti. I think if we both do, but those were different days, you know, that kind of residency training doesn't exist anymore.
Yeah, I think that was
batch.
Such a crucible, but you were amazing. My memory of you is being really kick-ass and making me look really good when I was on call with you. So, and I have to have you work with Jason, right? Mm-hmm. Dr. Jason James.
Dr. James. Uh-huh.
So who we also did residency with, and I'm going to have him on in the future.
Mm-hmm. Yeah, we were all for the same residency class, basically.
Yes. It was hard, but fun times too, mm-hmm. in between, right?
Definitely. Yes.
So Jila, what else would you like to add about your background? Like, what I often like to ask people to share whatever else they'd like, and also maybe share what got you to working on, doing the things you're doing now.
I think, after residency in New York, moving down to Miami, it was a whole different environment. And a lot of women, like from when we train and after we go into private practice, as I'm sure you know, we move a lot of different practices. Like it's not usually one and done. Like, you have to find your bearings. And I was lucky where, I joined the practice 21 years ago. And I stayed. Like I was just there doing my thing, and we all grew together. And we started out with 2 providers. I was the third, and we're up to 6 providers now in my practice. And so it's grown, it's evolved. We have grown and evolved. And, I think doing a lot of the obstetric part of things made it so that I've delivered so many babies and seen women through so many different parts of their lives. I've kind of grown with them. And so you see the evolution, and then you get to this point where they're asking you these questions. They're in their 40s now, they're done having their families and they're having issues. And I realized I was missing pieces. I didn't know what was happening. And I kind of had an idea, but not well-versed enough to take care of them the way we like to be able to provide answers for women. And And it was during our training that the WHI study was published.
Right.
Remember, that's when the headlines dropped, and I'll never forget. It was kind of like our attendings were like, well, I guess we're not going to be prescribing hormones. And it's, if they really need it, it'll be the lowest amount for the shortest time frame. But really, we were kind of shied away from it. And I don't think we even got that much training on it back then.
Right.
Yeah.
I mean, at that point, when we stopped doing that, it's like menopause care was kind of put on the back burner, right?
Yeah. I remember we're young. We weren't really paying attention to the ramifications of what this was going to look like. Fast forward 20 years. And that's where a lot of this started for me, was realizing we're missing pieces. And what does that look like? And why are we not able to address women's concerns appropriately, the way we're so strong with obstetrics and gynecologic surgery and everything else? We're so good at it. But this part was kind of like, it really stinks. I'm sorry. And it'll get better. That was the answer, and it didn't sit right. Mm-hmm. And I think it takes one to kind of experience it themselves, to notice something's off and to kind of drive it. Right. And I kind of started having symptoms, and I was like, something's off. Now I understand what these women were talking about. And I started, deep diving into it. And once you start, you can't stop. And it all opened up for me. And I was like, where have I been? Why am I behind the 8 ball? And this is not good. This needs to change. We need to change the conversation. And I started kind of poking around and realized, no, I'm behind everybody else nationally, but I'm not behind locally, because nobody was talking about it. It wasn't a thing.
I would say you're ahead of people. Honestly, there's people in practice not addressing perimenopause and menopausal changes like you are. I think you're doing quite a lot. And like you, I think most doctors of our age, right, like experience the same thing. Yeah. And over the years, we've had to learn based on trying to help our patients and help ourselves, like you said, and it's been, I guess we've all just been growing and learning actively together, and not everyone keeps up. So I credit you with keeping up, and I did see I think in your background, you mentioned, like, I read somewhere that you are an actively keep up with North American Menopause Society research and recommendations. So not everyone does that,
Listen, some people don't even know the Menopause Society exists. So that's kind of like where it's at, And when I was at the meeting last year, there's maybe 6,100 attendees maximum at the Menopause Society meeting. It's a national meeting. It's not new. It's been going on for years. And of the 6,100 plus, don't quote me on the number, it wasn't OBGYNs. We are part of it.
Oh, wow.
But it was other providers, other fields, primary care, emergency medicine, family practice, and then mid-level providers who were there getting educated, because that's where it's at. That's how we're providing care. But it really was a little bit disappointing to see our field, who should be front and center, not there. And I was like, what we're missing. This is the missing piece. And that's why so many of us are adamant about making changes on a bigger scale, meaning at the residency, at the training level, where this needs to be a bigger piece of the puzzle when residents are being trained. Right now, if you go to residency programs and ask the graduating residents of OBGYN how much they know about perimenopause and menopausal care, it's a sliver of what they should know, and they don't feel confident in it themselves. They will voice that. Hopefully in the next few years, that's going to evolve and change. But right this second, we're not there. We're not there at all.
Yeah, one of my former guests who's on the HPV vaccine episode, Dr. Amanda Selk, she mentioned, residency, which I thought was a really astute observation. Like, she mentioned that residency training really just focuses mostly on surgeries and obstetrics. So there's just not enough time spent. And you do have to you do have to make the effort to learn on your own and sometimes outside of residency, unfortunately. But I want to credit you also with now organizing your own events and educating, the women of your community, but also other doctors like myself. I really enjoyed visiting you in Miami last year
Mm-hmm.
at the at your event. It was the
Yeah.
Miami Menopause Collective event, right? I
Mm-hmm.
was really impressed with the number of women there.
Yeah. And the thing is, when you do things like that, you realize the lack of information and the lack of education in the community, and and how hungry women are for that information.
Right.
And how needed it is. So really, that's kind of what like it propulsed me even more into what I'm doing with more passion, because I was like, okay. And this was just a little 3-4 hour screening that we did. We really did the screening of the documentary, and we held a panel. And it could have gone on. You were there the first time. It could have kept going had there,
Right.
people had more questions. And that's kind of where I was like, okay, you know what? I see the need. I see what I can do with it. So it was when I realized from there was that, okay, I need to do something. And that's where the Empower Miami event was kind of created for April of 25. It was just like 2 months ago. And that one was a bigger event. It was an all-day event where
Okay.
we had like about 18 different speakers from across the country come in. And
Wow.
I kind of had met these docs and, providers across the country, at different meetings and society things, and knew who would be, the perfect match to kind of bring it all home. It wasn't just OBGYNs. It was a combination. I had a, mental health therapist. I had a psychiatrist. It was all different aspects of women's health brought together for one day, 8 hours of just talks. And what happened was there was so many speakers, I had to make them panels because we didn't really have the time to, it was probably like a 2-day event that was,
It's
compacted in
fantastic.
one day. But it was
Great
amazing.
job. Great
It was
job. It's been really fun following what
watching
you're
that.
doing out there. You're inspiring me.
Good. I'm glad.
So, yeah. So the reason I wanted to bring up this topic is I just love that perimenopause and menopause are having a moment now, because I very much feel that women's aging has just been such a source of shame in the patriarchy, like we didn't want to, women are so valued for youth and fertility in our culture,
Mhm.
and so women weren't talking about the changes that happen with aging, and so women don't know about that. And so it's just nice now to see how open it is, how women are sharing all the changes that are happening, what are some things that we can do to treat that. And so I guess I wanted to also talk about perimenopause. Like, that is not something, honestly, anyone ever talked about until the last few years.
Mhm.
So would you like to define for us
Sure.
perimenopause?
I think the definitions will make a big difference for women to understand. Is that, everything we've always heard is menopause, 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 no periods and hot flashes. That's it. That's really what most people can relate to. The thing is, there is a whole 5 to 10 year window prior to menopause, the perimenopause stage, that can really be devastating for some women if they don't know what's happening to them, what they're going through, and that it's normal and it will improve, and that there's support and resources for it. So the number one thing is to realize, hey, you're in it. Number one, okay? Just because you're having periods doesn't mean you're not in perimenopause. Perimenopause can start anywhere in the late 30s, early 40s, and last up to 10 years, getting you to 51, which is the average age of menopause. And like we said, menopause is one day of your life. It's one day after 12 months of not having a period. Then that day is defined as menopause. And any day after that, you're in postmenopause until the day you pass away. So we're spending a good 30-40% of our lives in postmenopause, yet we're not doing much about it. And so that's why, to attack women in the perimenopause stage, to educate them so they know, okay, this is what's happening to me. They can be moody. There could be mental health issues. There could be marriage relationship problems. Why? Because they're moody. Their partner doesn't think that they're interested in them. They don't want to be intimate with their partner. So it causes problems, in the relationship, and then can lead to marriage problems and divorce. There's a good 30-40% of women who will say later, oh, I think that could have been a component of what was happening. My partner wasn't aware of what I was going through and wasn't being supportive. So you have that part of it happening. Then you have your kids, your children, your family. They're being affected by what you're going through, yet the patient can't even identify what it is that they're going through. Because as we know, women, we're expected to do everything. We wear all the hats, right? We're the mom, we're the entrepreneur, we're the provider, we do everything. Now you cannot juggle everything the same. Your fuse has shortened. You're tired all the time. You just don't feel like doing things. You don't feel like yourself. And these are the things we hear over and over again. And women can go to 4 to 5 different providers and be dismissed. Well, are you still having a period? Yes. Oh, then you're not in menopause. It's not that. And nope, you'll be okay. Or even worse, I think, than that is, well, are you depressed? Yeah. And you're having anxiety. So here's some antidepressants and some, a little Xanax and some anti-anxiety medication to calm or Band-Aid over the symptoms. But nobody is talking to patients. No one's talking to women and saying, let's sit down and go through everything. Could it be your hormones? You're in that time frame. Maybe we should look at that. Now, again, it's a clinical diagnosis more than anything else, because we know blood work may not show whether you're in perimenopause or not. And there are other diseases, right, that can mimic perimenopause, all of these changes. It could be iron deficiency, can make you really tired all the time. A thyroid dysfunction can cause the same kind of, symptoms. And so you need to look at everything as a whole and then go from there and, address things appropriate. But women aren't given that time when they go for their checkup.
I love that you mention how early it can start in your 30s, because I think that's very surprising to women, and that has real consequences, like your fertility, and it's very much tied together. And so this is why another reason this topic is so important. But do you want to explain, maybe, I do want to break down, well, I guess, what are some, I guess that maybe we'll go over the different symptoms, like break it down. Okay. So I often find patients, one of the biggest signs is some changes in their periods, right? So do you want to talk about maybe what you see most commonly? Like, what kind of changes can you expect in your 30s to 40s as you're getting closer to menopause?
So some of the most common things we see is cycle irregularities. So either the periods are longer or they're shorter, or they happen to start skipping periods, or any kind of variation on that. That could be something we see a lot of. Some other things is really the mood issues, where they're just more irritable, maybe more short-tempered. Their PMS symptoms have actually exaggerated right before their period. Women with a history, it can be really, bad. And they cannot, it's kind of like an out of body experience where they see it happening, but they can't do anything to stop it. They can't control.
I also for these period changes, I often like to point out there are certain things that would be more normal changes that we wouldn't get too alarmed about, like, dropping a cycle here or there, or skipping periods, but the overall amount of bleeding and periods being somewhat normal or lighter. And like, for me, what I consider a red flag would be like more bleeding than normal, more frequent bleeding than normal, and that's an indication for doing a workup for something like,
At least.
polyps or fibroids or even
Any kind of
cancer.
dysfunctional bleeding, basically. Yeah,
Right,
absolutely. You
right.
have to double check everything.
And then to your point, yeah, some women's PMS symptoms, which they may not have experienced before, can become a new things, a new period issues like that, which you don't necessarily have to treat with like a mood stabilizing
Stabilizer.
drug.
Yeah.
Right.
Yeah.
Okay. Another thing is, of course, like in menopause, you can experience hot flashes and night sweats,
Mhm.
right?
Yeah.
But it may
They may
not.
not be as regular as what you get in menopause. Like they may not be every night, but you get a random one and you're like, wait, is this what this is supposed to feel like? Or the hot flash throughout the day or the night sweats where it wakes them up. They can have, and that can lead to sleep disturbances. So they're
Right.
not sleeping well throughout the night, or they fall asleep and they wake up at 2, 3 a.m. and they can't get back to sleep. And what does that do? That just sets off a whole fatigue cycle for them. Now that the next day they're tired, which then can
Mhm.
irritate them more and they become more moody and short tempered. So a lot of that is kind of tied in together. Another common one we get is brain fog. Like I can't remember the words, I can't get it out. Do I have Alzheimer's dementia kicking in? And literally, they'll go to a neurologist before kind of like piecing it together that, hey, maybe it isn't just that, maybe it's other things happening.
Mhm.
Those are the common ones, I think.
Right. I mean, I experienced, like at 40 something, some
Mhm,
brain fog, but
mhm,
also some memory issues. Like there was a point of time where I was experiencing. So I also kind of like to point out, like, this is the time to, if, in my case, it was a undiagnosed thyroid
mhm,
disorder. And things I experienced were actually being overly sleepy,
mhm. Yeah.
um, memory difficulty. I was walking around with sticky notes everywhere. Okay.
Mhm.
And interestingly, so I think that's an important thing to
Yeah.
check, at this time, of course. And yeah, I think difficulty concentrating, a lot of women say
Yeah.
that, right?
And also the ADHD, like they can't, if they have a history of ADHD, it's actually worsened through perimenopause, where the way they present is,
Really?
yeah,
I
they're on
wasn't
their
aware of that.
medication, they're
Hmm.
on their medication and they're controlled. And now all of a sudden, they need more or they need to increase their
Hmm.
dosage. And so these are all underlying things. Women with a history of postpartum depression, they're at a higher risk of developing depressive symptoms throughout
Hmm.
perimenopause. That's why a good
Yes.
number, of
And
women,
I've
myself,
had some, yes, I've
yeah,
had patients also with underlying anxiety disorder where that
mhm,
gets worse as well. Yeah.
yeah. Again,
Um,
by the time they get to me, they're already on antidepressants and anti-anxiety medications, and it's really, some of them now some patients are kind of more in tuned. And so they'll go to the primary will prescribe it and they will hold the prescription. And when they come to me, they're like, he gave it to me, but I didn't take it because I didn't think that was my problem. I think there's a bigger issue. I think it's my
mhm.
hormones. And so we're coming along, the discussions are being had, and women are kind of, taking a step back and not just treating the symptoms and actually getting to the root cause of things
Mhm.
before just jumping the gun and being on an antidepressant or an anxiolytic that they may not need necessarily.
Right. And besides like mental health changes, there's also all the physical changes, right?
Mm.
Like, what do you hear the most?
Oh, the weight
The
gain, the
right,
tire around the
right.
belly, where again, they're exercising the same, they're eating the same foods, they're doing everything as they've been doing, and the weight keeps
Mhm.
going up and up and up, or they just can't seem to shed it. And they
Mhm.
get really frustrated with that. And that's a big one that brings them in. And they're like, something's off. It's definitely, they think it's thyroid, and most of the time it doesn't.
Sometimes it is.
Sometimes
Right,
it is, but a
right.
lot of times with everything else, it turns out just to be the hormonal shifts happening that can then lead to inflammation and all the
Right.
other things
Right.
going on.
Metabolic changes. And
Metabolic syndrome, all of that. Yeah.
right. I think that's a great opportunity to remind them to, either, I don't know if you do it sounds like you do some metabolic,
Do
but,
testing and
I
workup.
often
Yeah.
refer patients back to their primary to,
Mhm.
get their that's the time of life. You should be checking your getting your cholesterol checked, testing for
Mm-hmm.
diabetes, and checking your blood pressure, things like that. And
Mm-hmm.
yeah. So, and then, yeah, I also, the other thing I experienced, of course, was super dry skin, but that was
Mm-hmm.
related to thyroid
The
problems.
thyroid.
But there are skin changes with perimenopause, and skin, bone, hair, all of
Mm-hmm.
those things are estrogen, influenced by
Mediated.
estrogen.
Yeah.
Right.
Well, we have estrogen receptors all over the body. And so the skin you lose the elasticity, it becomes more dry. And then that can even relate to intimacy problems where you need to be using lubrication, and intimacy is not the same as it used to be. And that could be due to vaginal changes happening from the lowered estrogen levels in your system. So
Right.
all preventative things that can be addressed. Or another, very common one that we miss all the time is recurrent infections, vaginal infections or UTIs,
UTIs. Yeah.
right? And we keep just treating
Right.
around with one antibiotic to the next. And the woman
Mhm.
tells you, I've never had this many UTIs in my life. I may have had one before. And now in the past 6 months, I've had 3 UTIs. That's a red flag. That means, hey,
Right.
let's dig a little deeper and see what else is going on. So again,
Mhm.
these are all the overall symptoms, again, head to toe, and you could be 42 years old and this is happening to you.
Right. Right.
So we need
And
to really pay
right,
attention.
sexual. You touched upon that, how
Mhm.
your sex life can change, and yeah, I see a lot of lower libido,
Mhm.
and even changes in ability to orgasm can be
Yes.
harder. Pain with sex.
And even
So.
the desire becomes less and less just because of the neurotransmitter changes in the brain that
Mhm,
happen.
mhm,
So even if they want to, they just don't have the desire for it. So the
mhm.
hypoactive sexual desire disorder kicks in, and then there's a whole nother, slew of events that can happen.
Right.
And then
Right.
they're just not even being intimate with their partner. And I hear what I think is really heartbreaking is when they say to me, well, I'm over, I'm 50 some years old. I mean, do I really need to be having sex anymore? And that for
Mhm,
me is just a no-go. I literally sit them down and I'm like, we're going to have a discussion.
mhm,
And your
mhm.
sex life is just as important as anything else in your life. It's your sexual health and well being. You need to be well. You're now at this point in your life where you're well established. You don't have to worry about, pregnancy or any of that anymore. And this is the bond of intimacy with your partner. So the fact that, you just want to discard it because you just don't think that that's part of it and like we're shriveled up and we're done, that's not the discussion here at all. We're a whole different generation of women where it's about intimacy, it's about exploration, and also knowing your body and what feels good for you. And sexual well being is a part of that.
I have heard that from patients and even friends, okay, telling
Mm-hmm.
me that they don't care if they
Yeah.
never have sex again. And so, yeah, my I tend to approach it a little bit differently in that I ask, well, does it bother you? Is it
Mm-hmm.
interfering with your life? And it's usually bothering them or their partner, or they're affecting their relationship. And so, yeah, I think most of the time it does need to be addressed. You shouldn't just ignore it.
Can't
Did
just
you?
ignore it. Yeah.
Right.
It's not okay.
Yes. And something you mentioned. So, yes, you don't need birth control when you hit menopause and you're postmenopausal. But before missing 12 months of your period, if you're still episodically having periods, you actually still need birth control because you never know what month you're going to ovulate.
Mm-hmm. Absolutely.
So, yeah, and actually, I guess that leads me into treatments, right? Like, because one treatment for some of these problems is birth control, right? So
Mm-hmm.
I'd love to hear your approach for patients. I guess it
I
depends.
think
You take the global picture, holistic
picture.
view of them.
So once we do the whole, evaluation and the blood work and the testing and their mammogram and their, pap smears and make sure everything is up to date and negative. And you have to do a full, background medical history, genetic history, make sure no history of, breast cancer, uterine cancer, any kind of, genetic mutation in their family. And the patient, most women will be candidates for hormone replacement therapy, And
Do
so,
you do? So I have a question about this because
yeah.
I've had some patients who have not hit menopause. They're perimenopausal. And
Mhm.
they, like, I don't tend to prescribe hormone replacement in perimenopause
Mhm.
because most will probably also need birth control.
Birth
But
control.
I have actually recently, in the last couple of weeks, I had a patient who used an online provider, I won't name
Mhm.
names,
Mhm.
but got hormone replacement therapy in
Mhm.
perimenopause. And I kind of disagreed with that, but what are your thoughts? How do you address
So you
it?
have to break it down. No two women are going to be the same. And so, different modalities and different treatment options for different women. When they're in that perimenopause stage and we've cleared them and they're candidates for whether it's an OCP or hormone therapy, then it goes to the back to the if they have contraception or not. If they have a bilateral tubal ligation or salpingectomy or some kind of permanent sterilization, whether the
Okay.
woman or her husband, if they have a vasectomy, the husband, then we don't need to. We can actually, we're better off, we're safer on
With
hormone
the
therapy.
lower.
And it's number one, it's lower. Number two, it's bioidentical. It's more what the body produces and recognizes as self versus OCPs, which are the synthetic hormones that we know of. So, and a lot of the newer data is coming out. It's really, and even the WHI was not estradiol or micronized progesterone. It was
Right.
ethinyl estradiol and the other progestins, medroxyprogesterone, and that. So we know that the bioidentical ones are less likely to cause problems. So that's why they're better off being on the hormone therapy, even at 42, than just to put them on OCP. So I do a
Okay.
lot of
Okay.
that.
So
And
if pregnancy is not a concern off the table,
you can
yeah,
consider that.
it makes
Yeah.
sense.
Uh-huh. And
Okay.
then
And then,
what if they
like,
don't have it? What if they don't have birth control? Then you can still mix and match a little bit.
hmm,
That's where the IUDs come into play. So you can use a progesterone
yeah.
containing IUD. So you're getting a double work out of that. So it's a contraception as well as their progestin to control or protect the lining of the uterus. And then you can do an estradiol replacement, a patch or a cream or a gel or a
Mhm,
mist or
mhm.
whatever you want, or even a ring at that point.
I
So
guess
I,
I'll
I
come.
mix and match.
I guess I'm going to come out and just say that that's my hormone replacement is estradiol. It was the
Mhm.
patch, but I have eczema, so I went to
Mhm.
the pill and
So,
an IUD to protect
yeah,
my uterus,
there you go.
a Mirena IUD.
Yeah,
So,
it works.
um, of course, a very big question we always get right in the office is testing for menopause. And I guess I want you to touch upon that a little bit and explain, because I have to explain all the time to patients, like,
Hmm.
why there isn't a good test, why we
Yeah,
can't just do a blood test and say, oh, yeah, you're 5 years from menopause, right?
right. Because so the ovary is, it's variable throughout the month, and day to day, it releases different levels of hormones, and so you cannot just rely on an estradiol or progesterone level or even an FSH level to determine whether a
Yes.
woman is in perimenopause or not. So it doesn't really give us a lot of information. The only
Mhm.
reason I do the baseline lab work is to rule out other conditions, as well as have a baseline, because we can use the baseline to kind of see how our treatment is going. So if they're feeling better on the regimen, then the numbers start to look a little different than if they haven't been on anything at all. And then until they go through menopause, then that FSH isn't going to start rising, or in a late perimenopause is where it starts to kind of creep up a little
Mhm.
bit. And then postmenopause, it kind of goes back down to normal anyway. So that's why we don't
So
have a good angle on a good test.
yes, I want to just add. So FSH
Uh-huh.
means follicle stimulating hormone, and that is a hormone that would be elevated when you're in menopause. And I tend to wait to check that when you've actually,
Gone through.
when we need to know, and I suspect menopause already,
Mhm.
like maybe someone's not had their period, for 12 months, but we're not sure, right?
Mhm.
So I tend to explain, like, we don't know what month you are your body is not going to ovulate and your estrogen
Mhm.
levels are going to be low. So like a spot check won't really, so, you
Won't
could
give
have
us
a
any.
normal, yeah, exactly. You can have a normal FSH or an abnormal FSH, and it still won't say anything about the next month, the following month, and the same with the estrogen levels. They can fluctuate wildly. So yeah, symptoms are what you can go on the most, right?
Yep. And perimenopause, really, it's all about symptom and looking at the clinical picture. Honestly, that's where you're going to be able to focus more than the blood work.
So yes, I agree. Yeah. I think I think sometimes, the other thing I wanted to mention, sometimes, patients will go to their primary or like these other, places and ask for a full hormone panel. And then they'll see me bring them in. And I usually, I do share, like, I wouldn't have done that. Like, you're telling me you have periods every month. Like, I could have told you your estrogen level was normal,
Be okay. Yeah.
Yeah. But anyway, okay. So tell me your approach for, like treatment. Like, let's start with lifestyle stuff. It sounds like you do a lot of lifestyle medicine. So that'll be kind of fun to hear about your approach to that.
A lot of women, they think they have the right diet modifications and this and that. And so we really have to break it down for them. And so I spend a lot of time going over what not to eliminate. We don't want to go into elimination mode. We're not dieting per se. We really want women to eat well every day, but include everything. You need protein, you need carbs, the good carbs, you need, fruits and vegetables, and you need, the good old oils and things like that in your food. So it's got to be a well-balanced diet. The Mediterranean or the DASH diet, those are the ones we talk about the most, just because it's, easier to address. It's not, you can visualize it. You need the protein, you need the green cruciferous vegetables there. And you need some carbohydrates in terms of like sweet potatoes or things that, even regular potatoes are okay. They're not, they've been so demonized where people are like just afraid of all of that. And I said, no, you can have a piece of toast with your breakfast in the morning. You can have eggs. You're supposed to. This is all good for you. So it's a lot of those changes, hydration, creatine, all of these supplements that we hear about. Again, I don't go crazy with the supplements because if they really have a well-balanced diet, I feel they're going to get the majority of the things they need. And then whatever else is missing, then we can kind of sprinkle it in as they go. And then I think the other big key component is movement. Exercise, just kind of making sure they get out every day, because a lot of people, unfortunately, we're more sedentary than we've ever been just because of work and job. And now everything's virtual. So we're seated more than we should be. And that, can be detrimental to our overall health and well-being and cardiovascular health. So it's making sure those two pillars of health are optimized the best way possible for women. And then kind of adding on as we go. Okay, so we've done that. We're doing better there. Now let's talk about what can we do? What are your major symptoms and how can we address them? And not everyone's going to be ready for hormone therapy right off the bat. Not everyone's going to come in and say, okay, put me on everything. There's still the fear of breast cancer because of hormone therapy and the WHI study. So we really need to be cognizant of that and not dismiss patients because they don't want to take hormones right away. There are other things we can do. There are non-hormonal options to relieve hot flashes. So we can use those. We can use local estrogen to treat the atrophy or the dryness, discomfort in the vaginal tissue. So there are other ways to go about it to get them to feel better. And sometimes even with the diet modifications, they can feel better enough to where their symptoms are controlled for a few more years in perimenopause. And then now they're well-versed, now they're more comfortable. And once the other worse symptoms start snowballing in, then they can be like, okay, I think now I'm ready to try some hormones. And then that's a whole different discussion.
Yeah. So yeah, I would like to really do a full episode on exercise. I might hit you up for your recommendation for a guest. I think what surprises women with the exercise, for example, is that we need to do a lot more than we really, I think in menopause, I remember there was a New York Times article. Now I forget how many minutes of exercise it recommended in a week, but especially important in the 40s when I start when women are starting to experience some of these perimenopause symptoms, I like to use it as an opportunity to remind them to work on more weight training, because women just spend so much time doing cardio over weights.
And that has to reverse. Like, we want them out walking, and we want them to do that portion of it, but that's just movement. They need to really increase the resistance training and add in the, smaller weights, and then build up on that, because you need to build muscle, and that muscle is what's going to maintain your bones and your bone health going forward. So we want to avoid, sarcopenia. We want to avoid osteopenia, osteoporosis. And that starts in your 40s. So you need to really be cognizant of all of these changes happening, so you can best kind of segue yourself into menopause, kind of being optimized the best way possible. Otherwise, by the time you get to menopause, you already have some of these things kicking in, and it's going to be a little bit harder to work on it. Not impossible, absolutely possible. There's, women in their 60s and 70s who look better than they did when they were in their 40s and 50s. So
I love that. It's amazing. It's amazing how you can transform at any time, any age, any time of life.
Anytime you can build muscle, you can do all of the above.
So just to explain a couple of terms, you said sarcopenia. That means muscle loss, right? That's what happens, as we age, as we get older, for everyone. And yeah, I think people tend to know what osteopenia and osteoporosis is: bone thinning, and then, to different degrees, bone loss, right? And so, weight training helps with those. But I also love to remind them that another reason we want to work on our muscles and do exercises like this is to be able to live independent lives longer, and being weak and frail in old age is going to get you into the nursing home faster. So,
and we all say that, what do you want to look like when you're 70, 80 years old? That's what you should be working on. Not really being thin. Being thin is not in anymore. It's all about being strong. So strength is really where it's at. And women are scared of it. They think, you say strength training and they think bulking up, muscular, a bodybuilder. And that's what we're talking about building lean muscle. That's it.
Yeah, another couple of thoughts I wanted to add for this time of life is to work on good sleep hygiene, to get better sleep. I think women have a lot of things on their mind, or busy people. But I find that, I've read a couple of books on sleep, and it is amazing how lack of sleep contributes, in a bad way to your overall health, So that's very important. And stress management, of course, we're all doing way too much, right? So meditation and stress management, exercises would be good. And then you mentioned creatine. I really have to look into these supplements. I will admit that I don't know much about them, and I'm a little suspicious of the supplement industry. So right now I don't make any recommendations like that, but that's going to maybe have to be a whole nother area I delve into. But vitamin D, calcium, of course, those are good.
Absolutely. Yes. We need those for our bones and for bone health. And the creatine is good. It's not just, it used to, again, be another gym thing and, for the bodybuilders to build muscle. But there's new data coming out that it's actually good for overall physical well-being as well as brain health and cognition.
Oh, and something else. So getting enough protein, of course, everyone's obsessed with getting
with protein.
I feel like all my meals, it's like, did I have enough protein?
Yes.
And it never is enough. And then fiber. I've been really much better about incorporating fiber. So that is also a game changer, especially when you're worrying about cholesterol, which I have to worry about thanks to my family history. Okay. Wow. We have really
gone through
a lot. Let me see. Let me make sure I don't have any other things I wanted to ask you while I have you. I think that's it. Do you have a closing thought about before I wind
just a
up?
couple of things so women can kind of understand where we're coming from and why this movement or wave of information that they're seeing everywhere about this topic is so big in midlife women's health is, only 2% of medical research funding is towards menopause related studies. They say it's for women's health, but it isn't for menopause. It's for obstetrics and it's for gynecology. So this is where all the discussions are coming into place. We get it. We're getting some money for women's health, but we need more specifically for this field of women's health. And a lot of women, we talked about this, but again, culturally, it's still a taboo.
Right.
Both the perimenopause and 4 out of 5 women will say no one talked to them about it, and none of their girlfriends want to own up to the fact that they're all going through it. So I want women to understand they're not alone. Everyone's going through it. Everybody will go through it. We're all going to go through perimenopause and menopause, whether we want to or not. Okay. But we need to have a community. We need to have resources, and women need to just kind of have grace with one another and just share what's worked for them, because you never know who's going to help next.
Thank you, Jila. Thank you for being a leader and a friend in this. So I would love for you to share where everyone can find you and follow
the
your
best
thoughts.
way to find me is on social media at Dr. Jila Senemar. Thank you for having me today. It was exciting to talk to you and catch up.
Yeah, you're very welcome. I'm sure we'll meet again online and offline.
I'm sure.
Okay, have a great day.
You as well. Thank you.
Okay, I'm going to leave with my closing thought. In the patriarchy, there is devaluation of aging women. We are all taught to believe that women's main value is their youth and their fertility. And so we've attached shame and embarrassment to the normal symptoms of aging that occur in perimenopause and menopause. But in the Gynarchy, we know that women's value isn't tied to our age or our fertility status. And we embrace aging as a normal part of life. And we welcome the transition to becoming older, wiser, more confident, and more powerful. So down with the patriarchy and up with the Gynarchy. Thank you so much for listening. If you've enjoyed this episode, please consider leaving us a review on one of the podcast platforms. Thank you so much. Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.